Good morning. My name is Amanda Dudelsack, and I'm a resident at Beth Israel Deaconess Medical Center in Boston. Today, I will be talking about choosing antibiotics and duration of treatment for emergency physicians facing positive urine cultures. I have no disclosures. Emergency physicians are often called upon to treat positive urine cultures, whether that be for their own primary patients, for sign-out patients, or in quality assurance follow-up. There are clear IDSA guidelines on when to treat a positive culture. However, there are no clear guidelines on how, as in with which antibiotics and for what duration. The objectives of this study are to elucidate current practice patterns among emergency physicians with regard to antibiotic choice and duration of treatment for positive urine cultures. The study involved a questionnaire that addressed 9 common clinical scenarios encountered in the emergency department follow-up of positive urine cultures. These scenarios were chosen to reflect the scope of practice for emergency physicians, as well as based on existing IDSA guidelines on when to treat. The scenarios included the following: a young asymptomatic female who is not pregnant, a postmenopausal asymptomatic female, a young symptomatic male, a pregnant female, an elderly female who fell who does not have urinary symptoms, an elderly male who fell who is confused, a middle-aged man who had a recent cystoscopy, an asymptomatic diabetic patient, and a renal transplant patient. The questionnaire was distributed by email across our BI Lahey Health Hospital network to current emergency residents, emergency attendings, and former affiliated emergency physicians. The responses were broken down based on years of training and then practice setting, whether that be in an academic center with an affiliated residency, a large community hospital, or a small community hospital. For each clinical scenario, emergency physicians were asked, what would you use to treat? And given the options of cephalexin, amoxicillin clavulenate, cefpodoxime, TMP SMX, or nitrofurantoin. They were also asked what duration they would choose to treat for, and given the options of 3, 5, 7, or 10 days. Choices were based upon most commonly prescribed antibiotics seen at our institution. The survey was sent out to 305 emergency physicians, and 120 emergency physicians completed the survey. 40.8% of those physicians were coming from academic hospitals with affiliated residencies, 37.5% from large community hospitals, and 21.7% in small community hospitals. Respondents included 14 residents, 33 attendings with less than 5 years of experience outside of training, 23 attendings 5 to 9 years out, 37 attendings 10 to 20 years out, and 13 attendings more than 20 years out. Across the board, the most common antibiotic chosen for all scenarios was cephalexin, with anywhere from 38 to 60% of emergency physicians choosing cephalexin, with the following exceptions. For renal transplant patients, cefpodoxime was the most commonly prescribed antibiotics. And then for an asymptomatic female, if an emergency physician did choose to treat a positive urine culture, the most commonly prescribed antibiotic for asymptomatic females was nitrofurantoin. Cipro and TMP SMX were almost never chosen. And then with regard to duration of treatment, in most scenarios, the vast majority of emergency physicians chose either 5 or 7 days duration, with a few exceptions. They chose to treat for longer, 7 to 10 days, for symptomatic males, indwelling Foleys, renal transplant patients, or elderly confused patients who had a fall. The widest array of practice variation was seen in symptomatic males and in renal transplant patients. For symptomatic males, emergency physicians chose to treat for anywhere from 5 to 10 days with a relatively normal distribution. And same goes for renal transplant patients, with emergency physicians choosing to treat anywhere from 5 to 10 days. So in a survey of 120 emergency physicians with varied levels of training and practice settings, most emergency physicians choose to treat positive urine cultures with 5 to 7 days of antibiotics. The most commonly prescribed antibiotic overall was cephalexin, and there was quite a wide variation in practice pattern, particularly with renal transplant patients and symptomatic males. While there are clear IDSA guidelines on when to treat a positive urine culture, there are no clear guidelines on antibiotic choice and duration. And based on this very wide array of practice variation, further research is needed to inform best practices. Thank you very much.
Hello guys, my name is Eric Chu. I'm from Bader-Scott All Science Medical Center at Fort Worth, Texas. Today, I would like to present our study, the association between hospital level and mortality in patients with COVID-19. I have nothing to disclose. As we know, COVID-19 outbreak is a global pandemic. It has been causing a huge burden to our country, especially our healthcare system. So I believe almost every hospital during the pandemic has capacity issue, and how to deal with the COVID patient or non-COVID patient or the hospital flow is kind of important. And we believe the capacity issue may cause the huge impact in patient mortality of COVID-19. So our study would like to investigate the mortality variations of COVID-19 from different hospital settings during different pandemic phases. It was the retrospective multicenter cohort study. We enrolled patients from 5 ED of Bader-Scott healthcare system in North Texas. We have 2 urban hospitals and 3 suburban hospitals. We enrolled that patient visiting ER between March and November 2020. Our primary outcome is the association between hospital level and 30-day mortality of COVID-19 patients. We use logistic regression models to investigate the associations between variables of interest and outcomes. In our results, we have 1,788 COVID-19 patients, 59.5% in urban hospitals. The mean age is 54.6, 50% male gender, and 197 death. So this is the flow chart. Initially we have more than 7,000 patients, and in the end we have 1,788 patients in our analysis. We only enrolled a first ED visit, and we do not have any transfer patient in our cohort. So in our cohort, we try to divide this pandemic into 3 phases. The first phase is starting in March and April. It's kind of the beginning of the pandemic. So we do have a surge of the mortality. The good thing is because the hospital was not that busy, so the ED volume was dropping. We have more capacity to deal with the COVID patient. But the problem is because we do not have a good understanding about the disease. So I believe that's kind of the main reason we still have high mortality. And the community start reopening because everything's kind of getting more control. But starting August 2020, we can see the big surge of mortality. At that time, it's kind of starting into the wintertime. So the ED volume increase. Our capacity drops a lot because we have COVID patient. We also have non-COVID patients. So almost every hospital are full. We have very limited bed or ICU bed. So it's a big capacity issue. At that time, we can see the big difference in mortality between urban and suburban hospital. In our analysis, we can see the urban hospital and the phase 3, which is August to November, has significant impact to mortality. So in our cohort, we do see the increased rate of 30-day mortality with the urban hospital setting, especially starting August 2020. At that time, because we got huge ED number or volume, and can cause a big impact for the capacity. The limitation of this study included retrospective design, and we do have a cohort from the North Texas only, so may not represent the whole country. We see the big picture of the mortality, so we do not know the detailed course of hospitalization. So in conclusion, patients with COVID-19 who visit urban hospital may have higher mortality than suburban hospital. I hope we don't have to deal with COVID again, But if the COVID number as is rising again, we have to figure out how can we use our resources more wisely to the COVID patient versus non-COVID patient. Thank you for your attention. Please let me know any question, or you can shoot me the email. Thank you for that.
Hi, everyone. I'm Jack Healy, and I'm a first-year medical student at Texas Christian University and University of North Texas Health Science Center School of Medicine. And on behalf of my team at Baylor Scott and White Health, I'm really excited to share with you all our study on the clinical characteristics of COVID-19 patients with initial false negative COVID-19 testing in the emergency department. Before I begin, let me state that we have no conflicts of interest to disclose. Since the beginning of the pandemic, the gold standard for diagnosing COVID-19 has been by reverse transcriptase polymerase chain reaction testing. However, the accuracy of these tests is still under investigation. Furthermore, the window period after infection in which testing is most likely to produce a false negative result is not well defined. Why does this matter? Well, it matters because false negative COVID-19 test results may increase the spread of infection and waste valuable medical resources. So here's what we did. We designed a study that had two objectives. First, to compare the clinical characteristics of repeat emergency department visits among COVID-19 patients with an initial false negative test. And second, to identify early signs of COVID-19 infection in the emergency department during the window period. Here's how we did it. We designed a retrospective multi-center cohort study from 12 Baylor Scott and White Health emergency departments. We screened the medical record for patients who met our eligibility criteria from the time frame of June to August of 2020. So here's what we did. All patients in our study had to have 2 emergency department visits with a COVID-19 test by PCR at each visit. The first test had to be negative, and the second test had to be positive. And the time frame between those 2 visits had to be 30 days or less. So let me give you an example. Let's say someone comes to the emergency department with COVID-like symptoms, they get a PCR test and it's negative, but then they come back 12 days later. They get a second PCR test in the emergency department, and now this test result is positive. Well, we have reason to believe that this first test that they took at day 0, where they had a negative result, that was actually a false negative, and that they probably had COVID-19 infection at that point in time. And so here's what we did with our data. Our primary outcome of the study was to compare the clinical characteristics between the 2 emergency department visits. This is what we found. Take a look at our sample. We had 88 patients. The mean age was just under 50. 40% of the sample was male, 60% female. About a quarter of the sample was Hispanic. 38% of our sample had a history of smoking. The average body mass index was 32. And about half of our sample was privately insured, the other half having a different form of insurance or no insurance. Here's what we found. The most common early signs in their first emergency department visit among false negative COVID-19 patients were fever, nausea, dyspnea, lymphocytopenia, and abnormal chest X-ray findings. So in this chart, the bars represent the proportion of patients that had that sign, with the green bar being at the first emergency department visit and the blue bar the second visit. Here's what else we found. The mean duration of symptoms was significantly longer for the second emergency department visit compared to the first. So in the first, the average duration was 2.6 days of symptoms, compared to 3.6 days of symptoms in the second visit, and this difference was statistically significant. Our study had some limitations. First, because it's a retrospective observational study, we found associations, but we can't infer causality from these associations. Also, the study was conducted at one medical center in Texas, and although it was multi-site, these results may have a limited generalizability to other geographic regions. However, we still think that this study generates some important conclusions. First, that early COVID-19 testing within 3 days of symptom onset or less may be associated with false negative test results. And during this window period, the most common early signs of a COVID-19 diagnosis were lymphocytopenia, fever, nausea, and dyspnea. Finally, there were significant increases on hypoxia, abnormal chest X-ray infiltrates, and elevated AST in the second emergency department visit compared to the first. Thank you so much for your time. I really appreciate it. I'd love to answer any questions that you have. You can also find my email here and reach me there. Thank you so much.
Good morning to everyone. I'm Amina Abdul Razak, and today I'll be presenting my abstract titled Association between Remdesivir and Mortality among critically ill COVID-19 patients. My study is a meta-analysis. I'll be presenting my abstract on behalf of my team, which comprises of members all across the world from medical colleges across the world. Remdesivir is the first drug to get US FDA approval for the treatment of coronavirus. The WHO, however, continues to warn against its use after the poor solidarity trial results. This has led to a state of dilemma for doctors, leaving them skeptical of whether they should continue to recommend the drug or not. Furthermore, the European Society of Intensive Care Medicine has recently advised against remdesivir for critically ill COVID-19 patients, discouraging its use in intensive care units. Whether remdesivir can be used for all types of COVID-19 patients is of extreme interest. We performed a systematic search from electronic databases like PubMed, Cochrane, Scopus, and Embase from inception until 20th November 2020. And we performed this analysis on RevMal 5.4 using dichotomous data for select values. The unadjusted odd ratios were calculated applying Mantel-Hansel's random effects model. The primary outcome of interest was all-cause mortality in ventilated and non-ventilated patients. We also analyzed adverse events and 28-day all-cause mortality. A total of 5 studies with 7,133 patients were included. The remdesivir arm was associated with similar rates of all-cause mortality, 28-day all-cause mortality, and greater than 3 adverse events. Upper confidence interval 0.93. Odds ratio 0.93, upper confidence interval 0.80, lower confidence interval 1.08, p-value of 0.33, and I-square 0%. There was no heterogeneity. Also, for greater 3 adverse events, there was no statistically significant difference between the two groups. Odds ratio 0.80, upper confidence interval 0.64, lower confidence interval 1.00, and p-value of 0.05. However, remdesivir was associated with significant difference for non-ventilated patients. It was not found to be favorable for ventilated patients. Non-ventilated COVID-19 patients showed a significant lower in-hospital mortality rate as compared with patients requiring mechanical ventilatory support. Odds ratio 6.86, 95% confidence interval 5.39, p-value of less than 0.0001, which was statistically significant, and there was no heterogeneity among the studies. Therefore, we conclude that non-ventilated patients were associated with significant lower all-cause mortality rates. Prudent use of remdesivir is recommended in critically ill COVID-19 patients. Given the remdesivir's unclear benefits, future studies are warranted, focusing on its efficacy and safety for different types of COVID-19 patients. Thank you.
Hello, my name is Kim Stanford, and I'm going to be presenting today on rising syphilis rates during the early COVID-19 pandemic. I have no disclosures to report. So I'll be speaking to you today about the effect of the COVID-19 pandemic on STI rates, specifically on rates of syphilis we saw in our population in the ED. At the beginning of the pandemic, we had little idea of what effect the pandemic might have on STI rates, and still we don't really know how it's affected STI rates in general. We believed that the changes in behaviors that were necessitated by lockdowns might influence STI rates, might decrease them, or changes in social situation might actually lead to more risky behaviors, and closures of outpatient STI clinics and primary care clinics might lead to disruptions in diagnosis and treatment that could potentially increase STI rates. So we had a lot of hypotheses about what might happen, and wanted to find out what that looked like in our population. So our ED was actually pretty uniquely situated to analyze this because we have a universal syphilis screening program that's been in place since May 2019, so almost a year before the pandemic started. And in our program, we screen all ED patients who are under age 65 and haven't been screened in the past year for both HIV and syphilis. And you can see here the example of a best practice advisory or a pop-up alert that shows up to help remind our staff to ask about and order the testing. This is an opt-out program that all patients are eligible for and can participate in if they would like. So we looked at all of the patients who were screened for syphilis in our ED starting in June of 2019 through June of 2020. We looked at two periods. One was considered the pre-pandemic, so a baseline period for comparison, which was all of the data from June 2019 through March of 2020. We saw our first local cases of COVID in March of 2020 and considered that because the lockdown started then, that truly a pandemic period as far as STI transmission was concerned would be April, we could start in April of 2020, and then we had data to analyze through June of 2020. Our primary outcome was considered presumed active infection with syphilis, and that was defined as a combination of syphilis serology, so mainly looking at RPR, as well as patient history. So we took into account whether patients had been previously treated, how their RPR had changed over time, and we used health department records to come up with a definition that was not simply an RPR alone, but was an actual, hopefully an approximation of who had truly an infection that required treatment. And then we use log binomial regression to generate prevalence ratios between the periods. So this is a graph of our overall results. You can see here the number of ED patients that came in by month, which dropped a little bit early in the pandemic, but has mostly remained steady. And then the percentage of patients that we screened every month remained about steady, around 20 to 25%, and really didn't drop during the pandemic. And then in that red line, you can see our rates of presumed active syphilis. And so it stays more or less steady over the year before the pandemic, and then has a significant spike early in the pandemic, which you see there highlighted in pink on the right side. And in fact, our highest rates we've ever seen, which was 2.5% of our population having active syphilis infection, were during April of 2020. This is a complicated table, but I just want to highlight a couple of points about our results. So prior to the pandemic, our community prevalence of syphilis was actually 1.2%, which is quite high. It's a lot higher than we had previously thought, but it jumped up to 1.8% of our population during the first few months of the pandemic. Among females, this was particularly pronounced. Our female population had about a 0.7% prevalence before the pandemic, which jumped up to 1.2% during the pandemic. And as you know, females are a very important demographic for prevention of congenital syphilis. So this jump was actually very important to identify. And again, among young folks too, we saw that before the pandemic, during our baseline period, ages 18 to 24 represented about 11% of our syphilis infections. And then during the pandemic, that proportion jumped to almost 22%. So an almost doubling of the number who are represented by that 18 to 24 age group. And among women, this was even more pronounced. The number of women in the age group 18 to 24 was 9.3% of our total infections before the pandemic, and tripled to 31% of our infections among females during the pandemic. And lastly, you can see here that the rates of folks who had come in for STI-related complaints, these are things like discharge or genital rashes, actually remained about the same and decreased a little bit during the pandemic, which really implies that this does not represent a change in the location that people are seeking their STI care, but truly represents a change in community prevalence of syphilis. So in conclusion, we found a significant increase in syphilis rates early in the early months of the pandemic, which was particularly notable among women and young people who are key in terms of prevention of long-term consequences of syphilis, as well as prevention of congenital syphilis. It does not seem to represent a shift in location of STI care, but truly seems to represent an increase in community prevalence. And we truly believe that ED screening can represent a very important tool for syphilis prevention and control in high-risk populations. Thank you very much.
Hi, everybody. My name is Haley Scott. I'm a fourth-year medical student at the Renaissance School of Medicine at Stony Brook University. I will be presenting on bacterial infections and death among patients with COVID-19 versus non-COVID-19 patients with pneumonia. I have no disclosures. Many patients with COVID-19 present with radiologic evidence of pneumonia. A lot of the times it is hard to determine the etiology of the radiologic abnormalities, leading providers to empirically treat patients, assuming that they have bacterial pneumonia with antibiotics. Unnecessary antibiotic use can lead to the development of antibiotic resistance, as well as increased costs of medical care and adverse events such as allergic reactions and diarrhea. In our study, we compared the rates of bacterial infections and mortality in COVID-19 patients versus non-COVID-19 patients with pneumonia. Our study was a structured retrospective medical record review. Our subjects included patients admitted with a positive SARS-CoV-2 PCR from February to May 2020 and compared them to non-COVID-19 patients admitted with a clinical diagnosis of pneumonia between February and May of 2019. The data abstracted included baseline demographics, comorbidities, signs and symptoms, lab and microbiological results, and chest X-ray findings. To determine if any culture result was a true positive bacterial infection or simply a bad sample or a contaminated sample, we utilized the criteria here determined by our infectious disease team. For blood cultures, the coagulase negative skin flora listed above were excluded from true positive cultures and considered contaminants from a bad sample. For sputum cultures, more than 9 epithelial cells was considered a bad sample. Also, the lack of white blood cells was also considered a contaminant or bad sample, as that indicates no active inflammation. Any organism grown from a pleural culture was considered to be the causative agent of pneumonia, as is the sterile procedure. Finally, any positive urine antigen result was considered to be a true infection as well. For our study, our primary outcomes were mortality, also the presence of a culture or antigen-confirmed bacterial infection. Secondary outcomes included ICU admission and hospital length of stay. We compared the two cohorts, COVID and non-COVID patients respectively, utilizing univariable and multivariable analysis. Our hypothesis was as follows. The rate of positive bacterial cultures will be higher in the non-COVID patients with pneumonia than in those with COVID-19. As we found results, we saw that the baseline demographics, the COVID-19 patients were generally younger. Both groups were similar in sex distribution, having slightly more than 50% male in both cohorts. 97% of COVID patients and 93% of non-COVID patients had some sort of bacterial culture or test sent. This table shows a comparison of these patient baseline demographics. Compared with non-COVID-19 patients with pneumonia, the patients with COVID were younger, more likely to present with fever, hypoxemia, leukopenia, abnormal chest x-rays, and bilateral findings on chest x-ray. In contrast, the patients without COVID were more likely than the patients with COVID to present with lymphocytopenia, elevated creatinine, elevated procal, or elevated cardiac troponins. The P was less than 0.001 for all comparisons. Here's a graphic representation of some of the important numbers from our univariate analysis. The blue bars are the non-COVID patients, the red bars are the COVID patients. The p-values for all were less than 0.001, indicating statistical significance. The bacterial cultures were truly positive in more non-COVID patients. There were positive X-ray findings more frequently in the COVID patients, and they were also more frequently bilateral in the COVID patients. The COVID patients also had a higher rate of mortality at 15% versus 9% in the non-COVID cohort. Table 3 on the left shows the results of the bacterial cultures and antigens. True positive results consistent with bacterial infections were found in a higher proportion of patients without COVID pneumonia than the patients with COVID at 13% versus 8% respectively, with a p-value of less than 0.001. Table 4 on the right shows the bacterial isolates identified. Gram-positive organisms were more frequently identified in both cohorts. Staph aureus was the most frequently identified organism in both groups. However, notably, E. phasalis was much more frequently grown in COVID patients than in non-COVID patients. This table illustrates the results of our multivariable analysis. Multivariable predictors of death were increased age, male sex, tachypnea, hypoxemia, or any positive bacterial culture. Compared with non-COVID-19 patients with pneumonia, patients with COVID-19 were more likely to die. The presence of bacterial infection and COVID-19 were independently associated with mortality, even after adjusting for confounders. Variables associated with ICU admission included male sex, oxygen saturation less than 89%, any positive test, and a positive test COVID interaction. Predictor variables associated with prolonged length of stay included oxygen saturation less than 89%, ICU admission, bacterial infection, and COVID-19 status. The limitations of our study are as follows. Due to the retrospective nature of the study, we cannot exclude selection bias or residual confounders. While most patients were cultured, some were not. This may have underestimated the number of patients with bacterial infection. With more advanced microbiologic testing, like PCR or seroconversion, we may have detected more infections. We also cannot exclude errors in data entry and reporting. In addition, our study is retrospective in nature, and it is representative of a single academic suburban hospital near one of the first epicenters of COVID-19 pandemic and may not be representative of other settings. In conclusion, 8% of patients with COVID-19 have concomitant bacterial infections, which is lower than the 15% in non-COVID patients with pneumonia. Mortality was higher in COVID-19 patients after adjusting for age, sex, and bacterial infection. This leads to questioning the use of empiric antibiotics in COVID-19 treatment. Based on this data, should it be limited? The treatment and management of COVID-19 patients is, of course, evolving as the pandemic continues. Future work could include developing protocols that consider using antibiotics only in patients with radiologic evidence of pneumonia, such as lobar consolidation, or elevated inflammatory markers such as CRP and procalcitonin. Thank you for your time. That's all I have, and I'll field any questions now.
Hello, I'm Adam Singer, and I am going to be presenting on behalf of my co-authors noted here. Our title is Comparison of the First and Second COVID-19 Waves in a New York Hospital, and we have no disclosures. So in March 2020, we experienced our first wave of COVID-19 patients, which leveled off in the late spring. Then again, in the fall of 2020, the number of COVID-19 patients in RED began to climb again. Now, between these two waves, much has been learned regarding COVID-19 with regards to the epidemiology, diagnosis, and treatment. And therefore, our study objective was to compare the baseline characteristics and outcomes between the COVID-19 patients who presented during the first and second waves. So in February 2020, when the pandemic was beginning, we created an institutional registry of all patients who presented as persons under investigation with suspected COVID-19. Data was abstracted daily from the EHR and was supplemented with a manual chart review by trained personnel of all patients with suspected COVID-19. The data included baseline demographics, as well as comorbidities, signs and symptoms, laboratory results, and imaging. Outcomes of interest included admission to any floor, admission to the ICU, either immediately from the ED or later on, the use of invasive mechanical ventilation, and mortality. We used univariable and multivariable analysis to determine the association of various predictor variables and outcomes. And in particular, we were interested in the association of presenting during the first or second wave and outcomes after adjusting for severity and comorbidities. There were 2,825 patients who visited us during the first wave with COVID-19, and during the second wave, there were 527 patients with COVID-19. The groups were similar in age, sex, and comorbidities. Compared with the first wave, second wave patients were less likely to be from nursing homes, less likely to be healthcare workers, less likely to be Hispanic, and more likely to be white. Now, based on univariate analysis, you can see that the admission rates between the first and the second waves in blue and red were similar. However, the rate of ICU admissions was significantly less in patients during the second wave. The percentage of people who required invasive mechanical ventilation was significantly less during the second wave. However, mortality overall was similar. Here we present the adjusted outcomes based on logistic regression. With regards to the outcome admitted to the floor or the ICU, we can see the predictors of increased admission included age, the presence of tachypnea and fever, as well as hypoxemia and having more than one comorbidity. Using the first wave as a reference, the overall odds of admission was not different between the first and second wave. With regards to the need for ICU admission, again, predictors of ICU admission included male sex, tachypnea, the presence of fever, and progressive hypoxemia, as well as the presence of comorbidities. With comparison to the first wave, second wave patients had an odds ratio that was lower than during the first wave. With regards to mechanical ventilation with an invasive ventilator, you can see that predictors included the increasing age, male sex, tachypnea, fever, and hypoxemia, as well as comorbidities. And again, compared with the first wave, we can see a lower odds of need for ventilation during the second wave. And finally, with regards to mortality, again, predictors of mortality include increasing age, male sex, tachypnea, hypoxemia, and increasing comorbidities. And in comparison with patients who presented during the first wave, you can see that the odds of mortality were significantly less after adjusting for all of the comorbidities than during the first wave. Now, certainly, our study has several limitations, not the least of which include the fact that it's a single center. We had a lot of PPE and resources and were able to handle the increasing census. We also used a retrospective study design, which of course is subject to selection bias, as well as residual confounding, a number of factors that we may not have controlled for. In conclusion, compared with COVID-19 patients who presented during the first wave, outcomes were overall better for patients presenting during the second wave. This may have been done as a result of our improved understanding and treatment that occurred between the first and the second wave. Thank you so much.
Hello, my name is Lauren Dierks. I'm a first-year medical student at the University of Texas Southwestern. Today I'll be presenting about childcare providers' anxiety levels and SARS-CoV-2 testing. Little is known about the risk of transmission from children to adult or child to caregiver. And there's varying evidence about the role that children play in transmission of COVID-19. Being young, female, and inherent workplace cooperativity issues are associated with an increased risk of anxiety regarding COVID-19. And testing and knowledge about the virus is associated with a lower risk of anxiety related to COVID-19. So we've hypothesized that childcare providers will have a high rate of anxiety and that this level will decrease with testing for COVID-19 and antibodies. We have a prospective cohort of childcare providers from a city-funded childcare facility in Dallas, Texas, focusing on homeless children. We enrolled our participants starting in October of 2020. We've asked our 37 participants to report their exposures, symptoms, and prior testing before we did PCR and the Abbott IgG antibody test for them. We did repeat testing 6 weeks later in December of 2020, and we've used descriptive statistics to show the prevalence of COVID-19 in our population and the difference in anxiety scores. We've used the Zung self-rating anxiety score to show anxiety in baseline and a follow-up test. This was completed prior to each testing. It's a 20-question survey using a Likert scale, asking psychological and somatic questions. The lowest score you can get is 20, and the highest score you can get is 80. The cutoff point from normal to moderate anxiety is 45. Our population was mostly women. The median age was 49. 54% of our population had prior testing for COVID-19, with only one of those prior tests being positive for COVID-19. They showed a past medical history of diabetes, hypertension, and cancer. For the anxiety results, we showed a mean anxiety score of 32 in the initial round and 29 in the second round. There was no difference between anxiety score in the first and second round, and no change over time. However, we did find it interesting that in one of our questions, the question regarding "I feel that everything is all right and nothing bad will happen," only a quarter of our participants were able to say that they feel that way all or most of the time. For the testing results, we found a prevalence of 5.4% of the population having COVID-19, and 0 were seropositive for IgG in the initial round. 22 participants were able to say that they had no prior symptoms in the initial test, and a lot of our participants had prior testing prior to the initial test and testing on outside resources in the follow-up period. Limitations of this study: it was a small sample size based on city resources and access. A lot of our participants had substantial testing prior and during the study, so that could have affected the results of the anxiety score and might even have been different in the beginning of the pandemic. Also, it was a high-risk population of childcare providers, so it might not be generalizable. Overall, the level of anxiety was normal in the childcare providers, and it did not change over time. And the prevalence of COVID-19 in our population was 5% at enrollment. And we can compare this to the prevalence of COVID-19 in Dallas County during October to December 2020, which was 3%. Thank you.
Hi, everyone. My name is Jose Miguel Juarez. I'm an emergency medicine resident at Mount Sinai and Elmhurst in New York City. I would like to acknowledge my research team and members of our Elmhurst COVID-19 research group who have helped make this project possible. I would also like to thank SAEM for this opportunity to share our research. In this study, we investigated the impact of initial vital signs on outcomes of patients who present to the emergency department with COVID-19. We have no disclosures. The world has been hit hard by COVID-19. In the United States, to date, over 30 million cases have been identified, and over 550,000 deaths have been attributed to the virus. During COVID-19 surges, especially the first one, emergency departments have been faced with increased numbers of people presenting with varying levels of severity. Without a validated risk stratification tool, physicians have been faced with challenges triaging patients, allocating limited resources, and initiating interventions earlier on people at high risk for decompensation. Risk stratification tools may help with early identification of these higher risk patients, and many scores have been proposed throughout the world. However, none have been externally validated yet. Also, none are based solely on presenting characteristics, which might allow for earlier interventions. Our objective was to investigate whether presenting vital signs are associated with outcomes of COVID-19 patients, with the goal that information we gather will contribute to future research on risk stratification tool development. We conducted a retrospective cohort study at Elmhurst Emergency Department in Queens, New York. We included all adults who presented from March through May with confirmed COVID-19. We excluded patients who arrived with out-of-hospital cardiac arrest because most were already intubated and most never achieved ROSC, so vital signs were not available. We excluded patients who left during evaluation, such as those who left against medical advice, because their outcomes were not available. We investigated initial ED vital signs from triage and used these definitions for hypoxia, tachypnea, fever, tachycardia, and hypotension. Our primary outcome of interest was death. Secondary outcomes were ICU, intubation, and cardiac arrest. For the analysis, we developed multivariable logistic regression models adjusting for age, sex, and ethnicity. These are the baseline characteristics of our population. We enrolled over 2,000 patients. About 40% were age 50 and under, and another 40% were age 60 and over. About 70% identified as male, and about 60% identified as Hispanic or Latino. Of note, this initial dataset had missing values which are identified on the last column of this table. These missing values came from an issue with the EPIC data pool, and we are currently in the process of manually abstracting this data for reanalysis. These are the results of our multivariable analysis. Significant associations are highlighted in red. Older age was associated with increased odds of death, and male gender with increased odds of ICU and intubation. Hispanic Latino ethnicity was not significantly associated with any of the outcomes. Hypoxia and tachypnea were associated with increased odds of death, ICU, and intubation. Fever and tachycardia were associated with increased odds of intubation, and hypotension with increased odds of all the outcomes. Our results are consistent with prior studies that have found associations between vital signs and outcomes. Important implications include the development of risk stratification models, which might help improve triage and optimize resource allocation, especially during surges. The predictor data that we collected was all available at triage as part of the routine workflow, and most of it was objective, except for respiratory rate, making this a strength of this study. There were limitations in the retrospective and single center design, ethnic and gender diversity of the population, and number of missing values. In conclusion, our results suggest that vital sign abnormalities on initial presentation were associated with increased odds of poor outcomes. Prospective, multi-center, and more ethnically diverse studies are needed to support our findings. We recommend using these findings to develop risk stratification tools for early identification, early intervention, and hopefully improved outcomes of high-risk patients. Here are our references. Thank you so much, everyone. I'm happy to answer any questions you may have.
Hello, my name is Colton Whiteside. I'm the PGY2 Emergency Medicine Pharmacy resident at the University of New Mexico Hospital. Today, I'm presenting the abstract, Combination Antibiotic Therapy Does Not Decrease Clinical Failure Rate for Skin and Soft Tissue Infections. So skin and soft tissue infections are responsible for a large number of patient-physician encounters each year, especially in the emergency department. Typically, for treatment of these patients, they're classified either into the cellulitis group or an abscess or purulent skin and soft tissue group. And our treatment it consists of single agents targeted towards the most common pathogens that cause each one of those types of skin and soft tissue infections. However, even though it's not a guideline recommendation, we do observe that double coverage with 2 antibiotics to theoretically optimize coverage and cover both streptococcal and staphylococcal species is observed in the literature and in practice. Most commonly, a first-generation cephalosporin plus trimethoprim sulfamethoxazole is used for this indication. However, no studies have evaluated a tetracycline combined with the cephalosporin for combination therapy in a skin and soft tissue infection. The purpose of this study was to assess combination therapy with doxycycline and cephalexin versus antibiotic monotherapy with either cephalexin or doxycycline for skin and soft tissue infections in the emergency department. And our working hypothesis was that there'd be no difference in incidence of clinical failure when comparing these groups. So our primary objective was the incidence of clinical failure between patients who received a monotherapy versus combination therapy for skin and soft tissue infections. Some secondary objectives that we looked at were time to clinical failure and to describe antimicrobial prescribing patterns for skin and soft tissue infections in the emergency department. So these 4 criteria is how we define clinical failure. The first is documented worsening of infection on follow-up. The second is incision and drainage after the initial primary visit, or change in antibiotic therapy after the initial ED visit, and then hospitalization related to the index infection. So this means that the patient was hospitalized after their initial ED visit and discharged from the ED, and it was for the infection that they were hospitalized. The design of the study was a retrospective single center study. We identified patients through ICD-10 codes, and our time period that we evaluated was about 2 years. This is an interim analysis of 90 patients of a much larger study. We included patients who were over the age of 18 and had a primary reason for visiting the emergency department of skin and soft tissue infection. These patients also had to receive an outpatient prescription for doxycycline, cephalexin, or a combination of the two. We excluded patients who were admitted to the hospital on their primary visit, had chronic antibiotic therapy or chronic wound care, if they were pregnant, breastfeeding, incarcerated, or had received previous antibiotics for skin and soft tissue infection in the past 30 days. The demographics of our patients were pretty well matched. We had a mean age of about 45 years old, with a standard deviation of about 16 years in all 3 groups. The study population was primarily male and primarily white Hispanics, with past medical history of IV drug use being more predominant in the combination group and the doxycycline groups, and a past medical history of diabetes being pretty well matched between the 3 groups. Our primary outcome of clinical failure did not find any statistical differences between the when comparing the combination group to the doxycycline group, or when we compared the combination group to the cephalexin group. Other results that we found was that there was a median length of antibiotic therapy of about 7 days. The most common reason that a patient met the criteria that we set forth as clinical failure was worsening of infection, and that occurred in about 91% of the patients who met the clinical failure criteria. And then the median time to clinical failure was 2.7 days. In regards to culture results for this group of patients, 19 of the patients received INDs in the ED, 14 were in the doxycycline group, and 5 in the combination group. No incision and drainages in the cephalexin group. Of those INDs that they were able to culture, 5 resulted in positive cultures, with the majority of those being MRSA. Based on the results of this study, it's concluded that in the ED, patients with skin and soft tissue infections, single antibiotic therapy did not result in an increased incidence of clinical failure compared to combination therapy with a first-generation cephalosporin and doxycycline.
Hello, everybody. My name is Nuzhat Sheikh. I am currently a Clinical Research Coordinator Associate at Maldonado Lab. Today, I'm going to present a poster on a prospective cohort study, which is regarding natural history of shedding and household transmission of SARS-CoV-2. As we all know, COVID-19 pandemic caused by novel SARS-CoV-2 is a major global health crisis, and the modes of transmission of SARS-CoV-2 is majorly through contact with primarily infected person and also through contaminated surface. Household contacts of an infected inhabitant are at high risk for becoming infected. While the overall estimated household secondary attack rate has been estimated to be 17%, the risk for transmission between close contacts is multifactorial. Demographic factors including age, gender, and socioeconomic status have been associated with alterations in the secondary attack rate. However, the effects of these parameters within household remains unclear. In addition to that, while public health guidance for index cases includes self-isolation and masks in shared spaces, the kinetics of SARS-CoV-2 transmission in these high-risk spaces are poorly understood. So, on the basis of that, our objective with this study is to estimate the secondary attack rate of SARS-CoV-2 within households and to further define risk factors for secondary cases due to household transmission of the virus. We tried to answer these questions by designing a study in which we recruited 37 households, including 37 index cases and 62 household contacts or secondary households from recently diagnosed SARS-CoV-2 patients from March 2020 to March 2021. The study required participants to self-collect anterior nair swab that were tested daily for SARS-CoV-2 via reverse transcriptase polymerase chain reaction, which is an RT-PCR test. The daily swabs were collected until all the participating household members had tested negative for 7 consecutive days. That allowed us to compare sociodemographic variables across household contacts that did or did not shed SARS-CoV-2. In addition to that, individual characteristics like gender, age, race, ethnicity, comorbidities, and relationship to index cases for secondary contacts, as well as household level characteristics like primary income, household density, and square feet per person on a property were reported. Also, CT values, which is a cycle threshold values, were collected for each positive samples. These CT values represent the number of cycles required for detection of the target, which is the virus, in RT-PCR test. We have chart depicting the data about CT values over here, but sadly, I'm not going to be able to discuss that during my presentation. But I welcome you to ask any questions you might have about that during our Q&A session. The table particularly shines the light on our household contact variables. To summarize some of the important findings, out of 99 participants in this study, 51% were women. Mean age of our participant was 40.8. 49 participants were white and 33 participants were Hispanic, Latinx. Out of 31 households with household contacts, secondary transmission occurred in 14 households, which is 45.2%, and 25 household contacts, which is 40.3%. We also observed that secondary attack rate was highest among those with close contact with index cases, such as spouses, which is 36.8%, and adult children caring for an older parent, which is 100%. Households whose income came primarily from service work saw greater risk of household transmission, which is 71.4% when compared to households with higher salaries, such as in technology, which is 37.5% with secondary infection. Highlighting some of the key conclusions now, our study demonstrated a higher secondary attack rate within households, almost triple the current estimate of 17%. Secondly, socioeconomic status seems to be a major driver of this increased risk of transmission, as proxied by our primary income data. Cycle threshold rises quickly over the course of infection, providing support for current CDC guidelines to limit the quarantine period to 10 days instead of 14. However, our prolonged shedding duration in our study, which was from day 9 to day 62, does indicate that qualitative PCR results may not always be sufficient to make determinations regarding best isolation policies for patients. Household contacts under 18 were at lower risk of infection, which is 27.8% when compared to adult contacts between 39 to 49 years of age, which is 45.5%. This might be linked to a hypothesis, which would be children's immune system are affected differently than adults. And we would need more data and evidence towards it. Hopefully in our next phase of our study, we'll be able to shine more light towards that hypothesis. This study suggests that household transmission represents a key source of community-based infection of SARS-CoV-2. Allocating resources for education and training of infected individuals and their close contacts will be critical for control of future outbreaks of SARS-CoV-2. Finally, I would like to thank all of you for listening to our poster presentation today and also for attending this pediatrics retreat conference. Though we would have enjoyed presenting this paper in person, I would like to say even this virtual opportunity we have is great, which not everybody has access to yet. Continue to stay safe. Bye for now. Please feel free to reach out to me if you have any questions via email. My email address is njsheikh@stanford.edu. Thank you. Have a good one.
Hi, everyone. My name is Chioma Ojiaku, and I'm a PGY3 resident at Cleveland Clinic, Akron General, and today I will be presenting my research titled Evaluation of Aggressive Fluid Resuscitation in Sepsis Patients with End-Stage Renal Disease. I have no disclosures. And the reason I performed this study was because sometimes ER physicians can be hesitant to administer the recommended 30 cc per kilobolus of fluids to patients who are at risk of fluid overload, such as patients with end-stage renal disease. So my primary objective of this study was to identify ESRD patients who were diagnosed with either severe sepsis or septic shock and received the recommended 30 cc per kilobolus of fluids and compare their mortality rate and their outcomes to patients who did not receive the recommended fluid bolus in the emergency department. The secondary objectives were to determine and compare the hospital length of stay of these patients, the ICU length of stay, the in-hospital development of pulmonary edema, the use of non-invasive ventilation, and the use of intubation. The study design was a multi-center retrospective cohort study in which patients who were 18 years of age and older were identified using the hospital's EMR system, EPIC, between January 1st, 2011 and December 31st, 2019. The inclusion criteria was patients who, we identified patients who had a pre-existing diagnosis of ESRD, patients who were diagnosed with either severe sepsis or septic shock during the study timeframe, and patients who received intravenous fluids while they were in the emergency department. Patients who had congestive heart failure were excluded because I just wanted to focus primarily on patients with ESRD. Data was collected using the REDCap data sheet, and we looked at the patient's demographics, their past medical history, the amount of intravenous fluids they received in the emergency department, and we also looked at the Charleston Comorbidity Index. A total of 355 patients were identified with the median age of 68. Majority of these patients were males. We also looked at their race, and majority of the patients identified were Black, 42% of the patients were white, and 4% of the patients were multiracial. When we looked at the body mass index, we found that majority of the patients in the study were obese. So 99 patients received the recommended fluid bolus and 256 patients received the restricted fluid bolus, as you can see from the pie chart. When we looked at the difference in mortality, we found that 18 patients who received the recommended fluid bolus did not survive, and 39 patients who received the restricted fluid bolus did not survive. And based on our statistical analysis of these patients, we found that there was no significant difference in the mortality rate between both groups of patients. And this was for an odds ratio of 0.85 and a 95% confidence interval of 0.46 to 1.59. The bar chart here shows the ICU length of stay, and 88 patients who received the recommended fluid bolus were admitted to the ICU, whereas 221 patients who received the restricted fluid bolus were admitted to the ICU. And based on our statistical analysis on the ICU length of stay amongst these patients, we found that there was no significant difference in the ICU length of stay between both groups of patients. And this was for a 95% confidence interval of minus 0.32 to 0.96. We also looked at the in-hospital development of pulmonary edema and found that there was no significant difference between the two groups of patients. This was for an adjusted odds ratio of 0.50 and a 95% confidence interval of 0.17 to 1.48. When we looked at the use of non-invasive ventilation, we found that majority of the patients did not require non-invasive ventilation. 5 patients that received the recommended fluid bolus were placed on BiPAP, and 6 patients who received the restricted fluid bolus were placed on BiPAP. And based on our analysis on those patients, we found that there was no significant difference in the use of non-invasive ventilation between the 2 groups. And this was for a p-value of 0.2271. We also found that none of the patients in the study were intubated. In conclusion, we found that patients who have end-stage renal disease and were diagnosed with either severe sepsis or septic shock in the emergency department had no significant difference in mortality, ICU length of stay, development of pulmonary edema, and use of non-invasive ventilation when they were compared to their counterpart patients who received a restricted fluid bolus in the emergency department. And based on that, the surviving sepsis guidelines should be followed for these patients. I would like to thank my co-authors and everyone who assisted me with the study.